Live no, doctor.
Well, thank you, Manju. So good evening, dear colleagues, distinguished faculty and participants. On behalf of the Tamil Nadu Ophthalmic Association, it gives me great pleasure to welcome you all to the Retina webinar being held on the occasion of the World Diabetes Day. Although today's program is not centered on diabetic eye disease, it highlights several equally important and complex areas of retinal care, such as management of ocular trauma, retinal dystrophies, retinoblastoma, and evolving field of choroidal imaging. Each of these topics play a crucial role in our understanding of retinal pathology and directly impacts the quality of care we provide to our patients. We are fortunate to have eminent speakers who will guide us through recent advances, diagnostic insights, and practical management strategies. We are honored to be joined today by a distinguished panel of retina specialists whose pioneering clinical and research contribution continue to shape the future eye care. The collective expertise will guide us through the latest advances, challenges, and opportunities in the rapidly evolving field of retinal disease management. Thank you all for your active participation and looking forward to an engaging and enlightening session. Before I move on, I'd like to introduce our moderator, Dr. Supriya Dabir Gautam. Manju? Yeah. So Dr. Supriya Dabir currently heads the Department of Vitreoretinal Services at Rajan Eye Care, Chennai, and she has spearheaded the setting up of the retinal department at the Voluntary Health Services. She has completed PhD in high-resolution imaging at the Maastricht University. She's a key academician, has won multiple accolades like the YKC Pandit Award and the Bashir Mahit Award. She has also co-edited the textbook of vitreoretinal diseases and surgery by the JP Publishers. I'm extremely thankful to Dr. Supriya for actually organizing the whole meeting and getting all of you together. We'll move on to the panelist. Manju. So we are extremely privileged to have one of the top, I would say, top ophthalmologist and of course a vitreoretinal surgeon, Dr. Lingam Gopal, with us. And he's a trained specialist in vitreoretinal diseases as well as neuro-ophthalmology. He's a postgraduate from PG Mer, Chandigarh, and did his vitreoretinal fellowship under Dr. S.S. Badrinath. He's also a trained epidemiologist from the University of London. And he's a fellow of the National Academy of Medical Sciences, New Delhi, and a fellow of the Royal College of Surgeons. He has published more than 230 papers in 38 chapters and received about 30 awards and ovations. He was a visiting professor at the University of Malay in Kuala Lumpur and also the National University Hospital at Singapore and LBP Hospital at Bhubaneswar. Welcome, Dr. Lingam Gopal. Next, we'll go on to Dr. S. Natarajan, who's a Padma Shri awardee and has performed over 60,000 exclusive vitreoretinal surgeries. Dr. Natarajan has trained more than 68 vitreoretinal surgeons across the globe and has presented more than 1,500 invited guest lectures globally. He is invited to teach as well as to speak in prestigious universities across the globe, and his work has been published in hundreds of international journals. I'm extremely privileged to be a student under both Dr. LG and Dr. S. Natarajan.
Thank you, Sujata.
Next, we'll go on to Dr. Dhanshri Ratra, and she is my daughter's mentor. So that gives her a special privilege as well. And Dr. Dhanshri Ratra is a senior vitreoretinal consultant at Shankar Nethralaya with extensive experience for over 27 years. She's also actively involved in research, having served as a principal investigator on multiple clinical trials and contributed extensively to academic journals. Her previous experience includes specialist consultant ophthalmology at Apollo Hospital, Bangalore and Sri Lanka, and overseas specialist at Dennis Lam Hospital, Shenzhen. Welcome, Dr. Dhanshri Ratra. Next, we'll go on to Dr. George Manayat, who's a senior consultant at VR Services, Arvind Eye Hospital, Coimbatore. He's performed more than 8,000 complex VR surgeries, 100 international publications on PubMed, a principal and co-investigator in multiple multicentric trials, has given more than 200 talks in national and international retina sessions. He's a scientific reviewer for British Journal of Ophthalmology and Indian Journal for Medical Research and the IJO. He's got the IGO AOS Gold Award in 2018 for the Best Scientific Publication and Vitreoretinal Society of India Best Scientific Poster Award. We're extremely privileged to have this wonderful panel of vitreoretinal surgeons to guide us through this discussion this evening. My sincere welcome to all of you and my gratitude for spending your time with us this evening. Thank you. Over to Dr. Supriya.
Thank you, ma'am. A very warm welcome to all our panelists and our speakers. I'd like to begin the CME for the day. with Dr. Jay Chabliani. Manjula, can you put on the slide, please? Thank you, Jay, for joining us this early in the morning. And you looked all nice and warm and cozy out there. So JC, as he's very fondly known back home. Manjula, can you change the slide, please? Go back, Ma. Go back. Back? Yeah, yes. Dr. Jay Chapliani is a professor of ophthalmology, a vitreoretinal surgeon who was here at Shankar Nethralaya, went on to LV Prasad, and is currently at Pittsburgh, where he also serves as the vice chair of the clinical research at the UPMC Vision Institute. He's founded the Choroidal Analysis and Research Lab, where he focuses on computational and biological research in choroidal diseases. So he is the go-to person for choroidal imaging, has authored more than 700 peer-reviewed publications, has written key reference books, is a reviewer of many high-impact journals, including the Science Translational Medicine, the Lancet, and on the editorial board for the AJO, American Journal of Ophthalmology. In addition to his academic contributions, he is also a member of the prestigious organization as a Macular Society and the Gonin Club. And he serves on the scientific committee for many of the international societies, including the AAO, the American Academy of Ophthalmology. He's delivered more than 250 invited lectures worldwide and has held visiting professorships at multiple universities, received numerous national and international awards, including several named lectureships. And Jay, we are very happy to have you back on your home ground again to talk to us and enlighten the whole Tamil Nadu Ophthalmic Association on what update there is in choroidal imaging. Thank you so much, Jay.
Thank you so much. Thanks, Supriya, for the kind introduction. Thanks, Sujata ma'am and Supriya for inviting me to this meeting. And I will be talking, and especially it's a privilege to speak in front of all my teachers, which is really under pressure. But yeah, it's good. So I will be talking one of my favorite topics on choroidal imaging. I know that few slides in the beginning would be probably repeat to many of you because you have seen that, but I had to really build up the introduction. But you will see that some of the newer technologies which we are coming up with and what we are now really bringing it to everybody to use. These are my financial disclosure. We co-founded a company called Netra Innovations, and I'll be talking some of the products of this company as well. So this is one of my financial disclosure which is relevant to this talk. We all know that choroid plays a very important role in the back of the eye, being a most vascular layer of the eye. And among the choroidal vessels, when we really look at, there are like multiple kinds of, I should say, multiple diameter choroidal vessels. And why it is important to learn about choroidal vessels, because they are the one who supply oxygen and nutrition to the photoreceptors, which are the more important cells in the retina. So we all have been talking about choroid for many years. We were doing ICG. We were looking at the choroid using ultrasound. Then came the OCT with spectral domain OCT. We started doing an EDI, which showed us a little bit more choroid. That is where my interest started. Then in over a decade, we have really evolved and gone into a much more detailed OCT called swept source OCT, where you can actually see the choroidal architecture as close as to the histology. So when I really think about choroidal analytics, we really talk about qualitative and quantitative. Qualitative, I'll be taking you all through some of these choroidal analytic parameter, which we have already been using in our clinical practice, as well as what is coming up in the future. So when we really talk about qualitative analysis, we start with wide field ICG, which is now available in many of the centers around the world, which allows you to actually see the choroidal vessels far in the periphery up to the vortex and beyond. So we also looked into the choroidal vasculature changes, what is happening in many diseases, and then we coined a term called venous overload choroidopathy, which clearly explains that the choroidal vessels are engorged in the periphery, causing the changes right in the macular region. We also talk about choroidal vascular hyperpermeability, where you can see that there is a hyperpermeability or increased hyperfluorescence on white field ICG, which is being used as a qualitative measure, but I'll show you in a bit about the quantitative of the hyperpermeability. Nowadays, we have multiple devices which can actually provide you a nice color-coded heat maps, which really shows you where the choroid is thickened or thin. And you can easily use this in the clinical practice and understand that, oh yeah, this area seems to be much thicker, and that's why this probably is contributing to the leakage, and we treat it. So let's jump on to the quantitative analysis of choroid, which is where my research interest has been for more than a decade. And I'll just show you some of the work which we have been doing in last 15 years. So thickness measurements, it used to be a pain to do these measurements manually, but now many devices have these automated analysis available, and something similar which I was talking about, that you can actually just look at the map and understand where the choroidal thickness is more. Way back, I would say almost 12, 13 years ago, where we started working on automated choroidal segmentation, because it is impossible to really do the measurements across all the scans of the volume. That's why we were interested in building up this automated choroidal segmentation to give us really the clue of the choroid. And then we came up with the binarized images and came up with the concept of choroidal vascularity index, which is being used in many diseases, which now has become an important choroidal biomarker. And we also published about using this choroidal vascularity and choroidal thickness in a feature of ETDRS map, which is what we are used to as a retina specialist. We also were interested in understanding the hyperreflective dots in the choroid, because we do see these hyperreflective dots in diseases ranging from CSR to even in inflammation. This is one of the examples from our paper showing the hyperreflective dots in CSR. And here I will show you hyperreflective dots in a patient with weak edge, where you can clearly see that the choroid is not only just thickened, but you can see these hyperreflective dots within the choroid. And here you can see that once the treatment was given and the fluid has completely gone, the contour has changed. But the more important is that the choroidal reflective dots have also come down. So this is a very important sign of inflammation, which can be used as a follow-up. When we think about choroidal vascular density, in addition to OCT, there are a lot of groups around the world where they have tried to use this ICG images and try to binarize the images to understand the choroidal vascularity. We also came up with a concept of choroidal vascular brightness, because I believe that this brightness itself can be different depending upon the pathology and how the contributory factors are. And then we eventually ended up doing a quantification of hyperpermeability using this method in collaboration with one of my colleagues in Korea, where we showed that how we can actually do the quantitative measurement of the hyperpermeability, because it really helps us to understand how it is changing with treatment. There are numerous parameters which are being used on white field ICG. I'm not going into the detail of that, but what I want to tell you is that choroid is becoming a very important biomarker in many diseases, not just CSR, but we have now imaging available, which can actually teach us a lot about these diseases. But being in the lab, we keep thinking what else is missing here. So we realize that we are not talking really about the surface of the choroid. Like I was just thinking that, when I look at the choroid, I really don't talk about the bumps or the surface. And then I figured that, maybe we need to come up with a surface evaluation, not just the vessels, not just the thickness. And that is where we came up with the concept of choroidal contour mapping. And just to explain to you that now just think about the choroidal scans and you'll think about the inner and the outer boundary. There is some curvature of the choroid within these two boundaries, which probably is defining the disease process. So we started working on this, and this is one of the GUIs which we created almost 4 or 5 years ago, and now we have multiple publications which I could not update my presentation. But this is like primarily just to explain to you that don't think about the thickness or the vessel, but think about just how the curvature of the choroid is also changing. And this is the inner surface of the choroid, and the next to it is the outer surface. And here you can see that how the radius of curvature at each point is changing for this contour. And this is something which we were interested to understand in various diseases. And then we looked into the quantitative analysis of these contour using the minimal principal curvature, minimal principal direction, and to understand why what is being defined in the choroid. And you'll be surprised to see this image. Just look at the top image of the AMD patient and the bottom image of the CSR, and here you can clearly see that how just the contour itself is so different between these two diseases. So I believe that this contour is also contributing somewhere in the pathogenesis of the diseases, which we are still ignoring. And we wanted to understand that, is there a difference between these two boundaries? And here you can see that there is a visible difference. And then we ended up publishing that in scientific reports. But before we really get on to diseases, we need to understand whether this actually is changing with age or not. And this example, you can clearly see that how there is a decrease in radius of curvature with increasing age and axial length. Let's move on to the 3D choroidal imaging, which was the dream in 2010. But now here we have over the year developed the various ways to do the automated choroidal analysis, tried to binarize the images, and now finally, I would say 3 years ago, we ended up creating a choroidal vascular map. This is my healthy eye, supposedly, where you can actually see the Heller vessels so clearly. And here the minimal cutoff we decided is 100 micron diameter, and here you can actually see the choroidal vessels in different sectors. You can actually do these numbers, and those numbers, what you're seeing is actually the choroidal vascularity, vessel volume or vascularity within that sector. So we have been using this tool for many diseases. We also came up with the 3D choroidal. This is what you get as a report, that how the choroidal vessels are seen, how is the CVI, how is the choroidal thickness, and this is how our team is doing the choroidal analysis of individual vessels. And you will see here that how we can actually identify each vessel, and you will be able to do the choroidal vessel diameter measurements. And now we have all these things automated, which we are showing in this arvo. We are submitting now, where we can actually see the variability index of the diameter. You can actually look into the tortuosity of the individual vessels, and that is something which I believe is very important. And you saw that we were actually doing the intervessel distance as well between these two vessels, and I'll show you in a second how these parameters are so different in different diseases. So one of my research fellow, Nicola, who visited us for 6 months, and he did a phenomenal job of looking into various choroidal vessels in 3D, comparing CSC and healthy eyes. And here you can now really talk about the choroidal vessel diameter in 3D, not just on the on-face or in the cross-sectional, but now you truly understand how the diameter is. We also looked into simple versus complex, which clearly showed a significant difference between these two. My research fellow, Alam, she has more interest in AMD, and she has been using these tools to understand the 3D choroidal vasculature difference in dry AMD, and we noticed that there was an increased intervessel distance in dry AMD compared to the healthy eyes. And there was actually a significant difference in the vessel diameter as well. And we were interested to understand how does this truly changes in patients with dry AMD, that is there a change with time? And we saw that in 1 year, even in 1 year, we were able to see there was an increased vessel diameter and intervessel distance. And this is something which we published recently in IOVS, where we showed that there is probably small vessel atrophy and the large vessel dilation in patients with dry AMD. And what about the patients who have one eye dry AMD and one eye wet AMD? And this is a very interesting paper, which we picked up this cohort, which had one eye dry, one eye wet, and we saw that the neovascular AMD eyes had larger vessels and decreased intervessel distance compared to their fellow dry AMD eyes. So, and also we were interested in diabetic retinopathy, which we published recently in IOVS, where we showed that there is a decrease in vessel diameter as well as in choroidal vascularity in eyes with diabetic retinopathy compared to the healthy eyes. But obviously, these things were done manually, and now we have a tool which can do the automated choroidal vessel measurements, including the diameter, including the tortuosity, which you will be able to see very soon. Choroidal flow is still missing. So we have a device called laser Doppler holography, which actually can show you a vessel information, including the differentiating the choroidal arteries from the veins in a non-invasive manner. And this is a very good example where you can clearly see that how it is differentiating from ICG. We are more interested in understanding that, how can we actually use LDH to look at the peripheral vessels. And here you can see that you can actually do the montage and understand the choroidal vasculature without injecting any dye. So I just wanted to bring up to you that I mentioned earlier that, we have now a startup called Netramind, and one of our tool, which is the choroidal analysis tool, is now available in Heidelberg, which is accessible across the globe if you have a HEYX2. And I just wanted to show you this video. So if you have interest in looking at the choroidal analysis using your Heidelberg images, you can use it. But right now, Heidelberg is already working on allowing the other images such as from Zeiss or Topcon to have this analysis using our tool. So I'll just play this video for the information. If you are interested, get in touch with me and I will help you to use this tool in your clinic.
Welcome to Netramind's choroid CVI analysis on Heidelberg's HEYX platform. On the dashboard, you can find Netramind's CVI analysis tool on the Appway tab to the right side. You can drag and drop any OCT volume onto the app to see its CVI and thickness analysis. The OCT volume is processed in the back end, and once the process is finished, you can find the CVI analysis in the Reports and Documents tab in the bottom pane. Once the volume is processed, you can see the report in the window or download the report to view it. Here you can see choroid thickness map and CVI map along with regional mean thickness values and regional mean CVI placed in EDDRS grids. The report also shows a table with the thickness and CVI values for easy access. At the end of the report, you can see 5 equally spaced B scans out of the OCT volume. The first column shows original B scans, second column shows choroid segmentation, third column shows binarized choroid vessels. To know more about us, please visit us at netramind.ai. Welcome to...
Sorry. So I'll conclude my presentation with this, just with these few comments that, the future of choroidal imaging involves becoming more wider, reaching to the periphery, which I think we are still lacking in terms of quantification. We are definitely pushing our boundaries to learn about the flow, not just the vessel structure. We definitely have many tools which can help us to do non-invasive test imaging, and certainly talking about the surface and the 3D, as you saw in the last few slides, definitely brings up a lot of information about the diseases. So with this, I would like to acknowledge all the funding agencies who have been supporting our research. This is a big team which I'm working with. I'm just lucky to have these smart guys around me. Thank you so much for your attention.
Thank you, Jay, for that wonderful talk. The kind of work that you're doing is just very inspiring and breathtaking, I must say, the images and the videos. Just to take away from all the various parameters that you spoke about, if you had to look at one parameter, something like how how when OCT came in, we all started looking at the fluid levels, subretinal fluid, intraretinal fluid, something quantitative which we would help in our clinical assessment of the patients. Among all these parameters, which is the one parameter that you would think may have a long way to go in our management of pachychoroidopathy?
I would say, first of all, thanks a lot for the comment. And I think that this is exactly what we always like, we have been doing research, we have been publishing, but what are we really taking it to the clinic is always a question. So this is where I think that our tool through NetraMind will help to standardize the biomarkers. And right now we have so many biomarkers, but we brought in only two right now, choroidal thickness and choroidal vascularity, with the goal that the clinicians will be able to see that and relate it with the previous visits or relate it with the other patients. I think that having a standard analysis, or I should say, using one device, one tool will bring up the standardization of the biomarker. And for now, I would say let's start with choroidal thickness maps as well as the choroidal vascularity, because I know that a lot of groups have been publishing in this area. But I think the biggest challenge, or I should say the biggest reason for people not trusting these biomarkers have been they are not standardized. So everybody does it on their own, everybody does it manually. So nobody knows what the ground truth is. So I think that using these standardized tool will help us and bring up the confidence to use it in the clinic.
Right, right. Moving on to the panel, Dr. George, I know you do extensive choroidal work with your specialty being in CSCR. What do you think is the clinical role of these parameters?
Yeah, good to see Jay once again, and good to see that you are exploring, the imaging of choroid in all the dimensions, the volume, the thickness and map and three-dimensional evaluation and all those things. Yeah, in your talk, you mentioned that we were doing ICG angiography. We are still doing, Jay. We are still doing a lot of ICG angiographies. And it's really, especially the wide field ICG angiography, really helping us to differentiate I mean, even the newer insights are still coming with ICG angiography, like, the venous overload choroidopathy, which I was talking in the last imaging congress also. But I think, as you said, you're standardizing and exploring these vessels in AMD to Pachy diseases. So I think it will give a lot of insights first into the disease pathomechanism. So this is how I think we learn more about, the origin of disease, which, for example, CSR once thought to be a disease of the, retinal vessels and then into RP, and now it's purely a choroidal disease. I think this is how it evolves. So I am thinking that more than the clinical application, as he rightly at this point, people look at choroidal thickness and probably the vascularity index. So I think when you explore these and find the intervascular distance and the volume and all these things, it will throw more light into the disease pathogenesis, and targeted therapies would probably evolve. That's my understanding. And, and also people talk about this choroidal hyperreflective foci in Pachy diseases as well as in inflammatory disease. So actually there is no way of quantifying as of now. So all these efforts, I think, will help in, helping the physician also, not only the research people, physician also to look at the treatment perspective with related to this biomarkers. Am I right, Jay? You would like to?
Absolutely. Absolutely. I'm glad that you were listening to me when I said the word were. I'm like, oh, I do ICG every day. You're absolutely right.
We do 10 to 15 ICGs a day still actually.
Yeah, all my patients undergo
Because
ICG.
we see, unlike now you are west and we are east, so in here we see a lot of PCVs, lot of we need to differentiate between PCV and AMD. We need to differentiate between post CSC CNVM versus pachyneovasculopathy. There are so many indications where
Yeah,
I mean,
absolutely.
especially if you are doing a volume retina practice, I think still we have a lot of, but then it's always multimodal. So you need to combine that with the other modalities which you are mentioning, including the swept source OCT, on-first OCT, and all these things will give more dimensions to the diagnosis and treatment.
Yeah.
Absolutely.
Yeah. Thank you, Dr. George. Another question to Dr. LG and Dr. Dhanashri. Which are the patients that you would send for a swept source OCT in the very busy clinic at SN that you have among your retina patients? Do all the patients undergo a swept source OCT, or do you categorize them on who gets that and who gets the spectral domain OCT?
Would you like to answer that, the Dhanashree?
Yes, sure, sir. Yeah, Supriya, that's a very nice question, because often when you just advise OCT, the fellow is also a little bit, in a confusion which OCT to order. So we don't order SS OCT for swept source OCT for each and every patient, but particularly a patient whom we want to study the deeper choroid or the deeper level, those patients we will specifically write for swept source OCT. And because obviously there is also the logistics of accommodating so many patients in one machine. So especially for patients with the CSR or patients with AMD, those are or patients like this VKH and other inflammatory disorders are the ones which we send for swept source OCT. But routine patients like say diabetic maculopathy, or say other AMD or myopic, that we need not send for swept source OCT. So sir, you would like to add anything?
Dr. Gopal?
Maybe.
Okay.
If I may just have one small comment, Supriya.
Yes, please.
So Jay mentioned about the difficulty in standardization, and he also showed that example of dry AMD in one eye and wet AMD in other eye. And that choroid is such a tissue. I mean, it's such a labile tissue, and there are so many variations in the choroid, and not just the age or the race, even the diurnal variation is there. The time of the day when you measure the choroid also matters. So there is a and not just from one eye to other eye, in the same eye also the location, it will be different in the macular area, and it will be different in the paramacular or the peripheral area. And if you have a macular atrophy, in the area of the atrophy it will be different, outside the area of atrophy it will be different. So there is so much of variation in the choroid. So I'm not sure, I mean, Jay can answer that. How exactly do you think we should analyze the choroid, and the standardization that you mentioned? I am sure it's a very tough thing to do.
This has been the struggle that everybody has been trying to do, and like you correctly said that the variation means if you had coffee, you climbed up the stairs, it just changes. I think that using the standardized tool is the only way we can do. But for the studies, what we usually do that, we define the patients at a specific time point, that between 9 to 12 or 9 to 11, something like this. And obviously that these changes has a range which happens. And I can tell you that as we published this many years ago, that this diurnal variation also is less as you get old. So obviously, what we expect in retinal vessels probably is happening in the choroidal vessels as well. But this is a constant struggle. So unless we keep looking at different ethnic groups, different time points, so we will have we don't have the best answers, but this is just a constant push towards that.
Yeah, and also it changes between machine to machine also. You know, the algorithms used in different machines are different. So
Yeah,
keep
yeah.
keep in mind, especially when interpreting the thickness and thing should be kept in mind.
Yeah, and this is one of the things which I learned after starting this commercial stage, that how difficult it is to actually build up these algorithms for individual machines, and even within the same patients, when because when we really deal with the real life, sometimes the patient was scanned on the spectralist machine, sometimes they are scanned on his eyes. So how do we actually interpret this? But I would say that we are aware of this problem, still not solved, but there will be very soon something will come up.
Super. Thank you so much, Jay. That's definitely work in progress. And looking forward to hearing a lot more from you in the future. Looking forward to using your Netra Mind also in our clinics. So thank you so much. Sir, Dr. Natarajan, you would like to add something?
I just wanted to tell the youngsters who are listening, I don't know whether everybody listened, is CV, 700 peer-reviewed publications and best retina groups in the world. Congratulations, Jay, and you are an inspiration for me.
Thank you. Oh, sir. Thank you so much. And your fitness is inspiration to all of us. All right. Thank you so much. Thanks, everybody. Have a great day.
Thank you so much. Now we'll move on to the next talk. Thank you, Jay. Thank you very much. It was lovely having you with us. We'll move on to the next talk. I think the next speaker, Dr. Ashwin, has not joined us yet. No. Can we move on to Dr. Ajoy? Move on to the next slide, Manjula, please. Yes. It gives me great pleasure in introducing Dr. Ajoy Vincent, whose research interests are in genetic eye diseases. His clinical interest is with inherited eye diseases, electrophysiology, mouse models, and genetic mechanisms. He's a professor of ophthalmology at the University of Toronto, a clinician scientist ophthalmologist in inherited retinal disorders, dystrophies, and electrophysiology at the Hospital for Sick Children in Toronto. He has authored over 90 peer-reviewed publications in ocular genetics and electrophysiology. He's been a part of Vitreoretina Society of India, the VRSI talks, has been a part of All India Association of Ophthalmology, AIOS talks. So it's been a real pleasure. This is the first time he's doing a talk with the Tamil Nadu Ophthalmic Association. So thank you so much for joining us, Ajoy, this early in the morning. And we'll start with his talk on an update on inherited retinal disorders. Over to you, Ajoy.
Good evening, everyone. Can you see my slide yet?
Yeah, we can see your slide, Ajay.
Thank you. Thanks,
Yeah.
Supriya, for inviting me. And one thing that Supriya didn't mention is Supriya and I go a long ways back, so we are co-residents, co-PGs, and thanks for having me. Following Jay's talk is going to be a difficult task, but I'm going to try. So today we'll be just talking about management of retinal dystrophy, specifically about Luxturna or RP65 results, because this is something, or I'm assuming all of us or all of you would have heard a lot about. So I have no financial disclosures that are relevant to this talk. So Luxturna is a gene replacement therapy which was approved by Health Canada in November 2020, and it was for the following indications. So for patients who have two disease-causing variants in RP65 genes within the age group of 4 and 65 years, who has viable retinal cells. So this was defined as presence of outer nuclear layer within the foveal scans, and whose visual acuity is 20/60 or worse, or 6/18 or worse, or whose visual fields is less than 20 degrees in any meridian. So Typically, patients who have two variants in the RPE65 gene cause Leber congenital amaurosis. It's an early onset disease which is characterized by nystagmus, poor vision, and ERGs are typically non-detectable. Amongst all cases of LCA, RPE65 is supposed to cover or almost occupy 6 to 10% of the disease load, and its prevalence is estimated to be 1 in 33,000. So today, I'll share with you our experience with the first 22 subjects who underwent Luxturna in both eyes. The age range in our cohort is between 9 and 44 years. Ours being a pediatric hospital, most of our patients were towards the younger side. There were 12 females. As part of our standard protocol, these patients all got 1 milligram per kilogram per day of oral steroids starting 3 days prior to surgery. Both eyes were treated between 1 and 3 weeks between the other eye, and the steroids were tapered 4 weeks after the second eye surgery. All underwent standard vitrectomy with subretinal injections. Uh, Approximately somewhere between 2 and 4 bleps were created in each eye. A total permissible volume of 0.3 ml was injected in total amongst these 4 bleps. And the parameters that we assessed, or which we'll discuss today, is changes in symptoms, visual acuity, visual fields as measured by kinetic Goldman visual perimetry, and full field stimulus test. And we'll also briefly discuss the commonly seen complications on follow-up. Our mean duration of follow-up or range is between 4 and 27 months, and the mean being about 13 months. So let's start with what the patients experience. All except 2 subjects reported subjective improvements in vision. What were these? Being able to see a star for the first time, or being able to walk from the car to home at night independently, or being able to go to the toilet or washroom in a movie theater without help, and being able to walk at night along sidewalks without bumping into people. 3 patients had negative experiences. One, although had transient improvement in dim light vision, our environment for 3 or 4 months, it deteriorated, and he felt that his symptoms didn't improve at the end, and he was 43 years of age. And one female at 40 years did not experience any meaningful improvement, whereas one specific individual who is 37 years old experienced a loss in distant vision, but noted that he could see better at night. Now let's see how the best corrected visual acuity, what happens to it pre and post surgery. So pre-op, the best corrected visual acuity in the right eye and left eye was 1.14 logMAR, so it's worse than 2200, about 2250 in either eye. And as you can see, even post-op, there is no marked or no significant change in visual acuity. So the bottom line is you do not expect a change in best corrected visual acuity. So we compared our data to a real world data. There is a registry study from Novartis. It's called Perceive study. It has 183 eyes enrolled as part of this large multi-center, multi-site study. And they also noticed that there is no significant change in BCVA following gene replacement therapy. Now, how about Goldman visual field diameter? So this would be the maximum diameter of the visual field across any meridian. So this is the right eye, left eye. If you look at pre-op, it is about 50 degrees in either eye. But note that there is a wide variability in visual field. So this is in part because like different patients are at different stages of disease, and it is in part because Goldman visual field in itself can be quite variable with up to 30 to 40% variability within intertest. But in effect, if you look at, the median Goldman visual field, it did not change. Um, uh, and if you look at the real world data from the perceived study, what you see is that in their cohort, they found that, approximately 7% showed an improvement at 1 month, which increased to 25% at 6 months. Whereas at 1 year mark, they found that, there was a decline in Goldman visual acuity, which invariably tells that there is an inherent variability in these data set and probably not a best outcome measure to report or to at least follow or define success. The next is the most important test for this cohort of patients. It's called full field stimulus test. It is a psychophysical test measuring the ability to discern predefined stimulus. So essentially what you do is that using a system, which is an ERG system, typically you give various intensity of light and you measure what is the dimmest intensity of light that the patient can see. So the patient has two options, yes and no. So to each stimulus, the patient would press whether the patient perceived the stimulus or not, and it'll come up with a threshold. So it follows somewhat similar to our Humphreys visual field, and you are measuring the dimmest light that the person can see before treatment. And this will be followed up at follow-up visits to see if the patient can now perceive still dimmer lights. So one important thing to notice is that when Luxturna was first approved, Novartis had conducted a maze test, which is called multi-luminance mobility test. So if you look here, this is pre-treatment. So they could only walk in, brighter environment. Whereas after treatment, patients could walk in much dimmer light levels, so the at least two light levels dimmer. And on the left, you will see the FST results from the clinical trial. It almost mirrors the result from the mobility maze. So as you can see here, patients can see dimmer light after treatment. And this FST is thought to originate in the most sensitive area of the retina, so it is also relevant from a perspective. So what is the results in our patients? So FST significantly improved, which means that the mean retinal sensitivity, or at least the most sensitive, not the mean retinal sensitivity, the most sensitive area of the retina got rescued. So pre-op, if you look at the right eye data, the patients could see about 10 - 10 decibels, whereas post-op, the patients could see lighter, about 26 decibels dimmer, which is about 250-fold change in retinal sensitivity. So you would see that all these patients improved on average at least 250-fold. So if you could see light which is like at a light of 250 units, so now you can see lights at 1 unit. So our results were better than the perceived study, which reported about 16 dB improvement in retinal sensitivity. Now let's discuss some of the complications. The most common complication was choroidal atrophy. As you know, in the last 3 years, there is increasing reports of choroidal atrophy that has been described in this cohort of patients. The first type of choroidal which is described is this like nummular, well-defined mid-peripheral changes that's defined as nummular choroidal atrophy. The second type, as you know, is the like touchdown retinal atrophy, which is seen at the area where you give the gene therapy injection. And there is a third variety which is not seen in the example that is given, is perifoveal, which actually comes very close to the fovea, and it is like a confluent serpiginous or scallop type of atrophy. So in our cohort, at least one type of atrophy was seen in about 2/3 to 70% of patients. In literature, The occurrence of these atrophy is somewhere between 12.6 to 50%. I think part of it is because like people only started looking for it in later publications. And but the current understanding is it does not affect patient experience. Although the report is it doesn't affect visual acuity or FST, which is true because our patients had still good improvement in FST. But what happens to fields? Looking at this extent of choroidal atrophy, my sense is that fields will be reduced, at least the retinal sensitivity in those areas where there is atrophy. But we still are awaiting data on that. The other thing that we saw is that a subfoveal atrophy was seen in a few eyes. So if you look at this patient, this is the one patient who experienced a loss in distance visual acuity. This is his pre-op OCT scans where there is some identifiable ellipsoid zone in the fovea. And this is the 3-month post-op scan where, you know, in the left eye clearly you see that there is loss of foveal EC, and in the right eye there is marked disruption with a flicker of subfoveal EC that you can see. And this patient's vision dropped from 2100 to 2300 and to 2125 to 2400 respectively. One of our patients actually developed full thickness macular hole, which was treated with a pars plana vitrectomy and a membrane peel at 3 months, and as you can see here, after the vitrectomy, the vision improved from 2400 to 2150. So other complications, 2 eyes of a patient developed subretinal bleed. This is because the retina was very atrophic and the surgeon was finding it very difficult to raise a bleb. Each time he would raise a bleb, there would be bleed. 2 of our patients had late onset retinal inflammation. To be very clear, immediate post-op and in the first few months, this patient did really well, but some of them developed some recalcitrant silent inflammation at about 1 year mark. And 6 eyes developed retinal tears during surgery, which was treated with endolaser without complications. So what are the take-home messages? It's that subretinal Luxturna for RP65 improves night vision in patients. Retinal sensitivity improves manifold in almost all patients and is best captured by FST in a clinical setting, unless you do some sort of a mobility maze in your clinical setting. Most importantly, BCVA is not expected to improve, and Goldman visual field or kinetic visual field is not a good test to monitor post-op. Chororetinal atrophy is common. It doesn't seem to affect FST threshold, but further studies are needed to see what is the effect of it or further follow-up. Immediate post-op inflammation is minimal. Higher pre-op steroids may decrease the incidence of later onset inflammation. Other complications are seen but do not seem to impact overall improvement or experience. With that, I want to thank, none of this is possible without a team effort. I'm just a cog in the wheel. And these are my colleagues, faculty members, fellows, imaging specialists, and technicians, and I'll be happy to take any questions. Thank you.
Thank you so much, Ajoy, for the wonderful talk. Anshula, can we have the screen back?
One second.
Yes. Dr. Natarajan and Dr. Lingam Gopal were the early ones in India to start, treatment and to start exploring options in inherited retinal disorders. I know that Dr. Natarajan used to do a lot of animal studies back then. Sir, Dr. Natarajan, would you like to add anything to this?
I think
Where we are in India, on the Indian scenario.
yes, and thank you, Ajay, for a wonderful thing. And I think one is how do you counsel the patient? Because I had 2 patients who wanted to do Luxturna. I said they're ready to spend any money, they'll go anywhere, but they didn't understand that they are not going to get visual acuity improvement. But I remember Stanislaw Rizzo, when he came for artificial retina surgery, he said, well, if the patient is going to pay from his pocket, don't allow the patient to operate, because even when somebody sponsored from him for his church, and one of them had a suicidal tendency. So how do you manage the expectation when you do a surgery which is so expensive? And I'm sure there the insurance is covering, but here in India, it's I think the estimate was something like 4 crores each eye. So, and even if they're willing to pay, I don't think it's worthwhile operating because their expectation is too much in India. And they think you can get normal vision, which is the toughest part, even for doing a inherited retinal degeneration genetic testing. They're not willing, because they ask, what is that we can offer back? But they don't understand we are creating a registry to see what type of genetic disorder they have. So how do you counsel the patient there?
Thanks. That's a very important question. And we actually have 2 sessions where we talk to the patient. So first is should be very explicitly be stated that this is not a cure. Because most patients think that, oh, if there is a treatment, is it a cure? So we very clearly state that we don't expect to see improvements in vision. But the changes in night vision are life altering for these patients. In Canada, the healthcare covers for it, so nobody has to pay from pocket. So it's a different scenario. But whatever experience that patients had subjectively, especially in younger children, it is life altering. One thing is that right now we did treat about 27 patients to date, and I was looking at the data last week of some of the patients. So the younger the patient, the greater the effect on the FST. So if you have a patient who is 20 years or younger, I think they will do really well, because you have one of the reasons why RP65 was selected for gene replacement in the first place is because, one, there was an animal model, and two, it was because that was a retina that is morphologically, structurally looking preserved relatively. So the thinking is that if you then do gene therapy, you can rescue function. So, and some of our pediatric patients got about close to 3 log, like about 1,000 units improvement or a fold improvement in their FST. So as long as you are able to say that this will not, if patients agree to the fact that it can improve their night vision and to some degree their side vision, then their expectation is realistic. But if they think that, oh, now they can drive a car, or their life is going to be significantly different, I think that is a tough ask. The second thing is that Novartis, to be frank, like they give 2 vials, and one is as a main syringe and one is as a backup syringe. Each vial has about 1 ml. So you only need 1/3 in principle to treat each eye. And one thing, is that Novartis actually also makes everyone sign an exclusivity agreement, which means that you can only treat one patient, even if you didn't have to use the backup syringe. So I think, like some sort of negotiations from, from the health regulatory bodies in India, or even, if the physicians can form a lobby and try to push back on some of these, I think the cost of this can become, I don't think it will ever become affordable, but it will become a bit more manageable. Even if you say you just need one vial, you don't need 2 vials. The cost can go down significantly. But otherwise, we actually talk to patients and family a second time to make sure that they don't have any pending questions or any unreasonable expectations. Yeah.
Good. Thank you.
Thank you, Ajoy. Dr. Gopal, what is your experience now that you're doing a lot of it at Singapore also?
No, I don't think we have any experience on gene therapy as yet. But what the question I would like to ask Dr. Joy, anyway, I would like to congratulate you for the excellent presentation. Just like to ask you that, do you think the site of injection had anything to do with the way the patients responded, where you could inject potentially in the mid periphery versus close to the macula? Was there a difference in the outcome?
That's also an excellent question, sir. So, absolutely. So, what we do routinely is that we do like large scans from macro using wide field OCT and see where in the retina the patient has some residual outer nuclear layer, and then look at the fundus images as well, and then inject in the areas where there is rescuable viable retina. So that's why we sometimes phrase 2 to 4 blebs. So in retina that is markedly atrophic, especially in older individuals where there is hardly any place to inject, those would be patients who did not have any improvement. So especially when I was showing the subjective improvement list, these patients were between 37 and 43 years. And you're absolutely right, sir, in that if their retina is damaged primarily, then where there is no space to inject, their post of experience will also be limited or improvement. That's a very important point. Thank you.
The other question I had is that we do understand that if you're injecting the blood, the size will be hardly maybe 1 disc diameter, 1.5 disc diameters in size, each site of injection. So if you cumulatively put 3 to 4 blebs of, we'll say, 1.5 disc diameters in size, that still doesn't cover a large area of retina to be able to expect any field enlargement. I understand that the retinal sensitivity has improved. Do you think it is because of some sort of a distant effect as well, in addition to the effect of the site of injection?
So that's also very fair comment. One thing we notice is that, once you start a bleb, sometimes you can never control a bleb, the direction, or some blebs go like vertically, some go horizontally. So some of the blebs actually, are maybe 2 or 3 diameters, some are just 1 diameter, it depends. But the thing is that, and then after you do, when you do the air fluid exchange, and the idea is that all these blebs kind of like there is a chance that they can coalesce if they are close to the area. So there is some effect of the spreading, but for the sake of the surgery and for the sake that to try to rescue the residual retina that has some function, we try to raise a bleb within area where there is some residual viable retina. But there will be, after the surgery, for sure, there'll be some spread. I'm not sure if it will spread all the way out, but there is some spread between, sometimes, you can even see, on the table, some of these blebs which are close to each other can coalesce. But the idea is that, after the air fluid exchange, some degree of spread will happen. Thank you.
Yeah. And the last question is that how much did the patients feel the improvement? I know on FST you have shown it, but did the patients feel the improvement and were they comfortable in walking around in dark?
Yeah, so that is the biggest improvement, sir. So all except 3 patients, so market improvements. So we had like a patient satisfaction questionnaire which we circulated, and like there are the kids who are autistic now, they walk around in the dark. These are life altering, and we hear from their school teachers that after the surgery the patient is no longer bumping too much. But these are things which are difficult to capture. And your point is very well taken that FST is not a mobility maze test. So the origin of the FST, or how much of the retina, or is it that a small amount of retina is rescued to a maximal effect, which gives this improvement in FST, you're artificially skewing. So efforts has been taken to see like which is the area from where the FST is originating these days. But and as I showed you in the field data, like if you look at all the fields and from all the patients, the mean fields did not change. We did have a few patients in whom there was a definite improvement in the fields, but on the contrary, we also had patients whose fields actually did not improve or got worse two or three. So your point is very valid, sir. So coming back to your question, I think that these patients' improvement in night vision, in dim light vision, actually is what is driving their satisfaction from based on what I can think.
Thank you.
Thank you so much, Ajoy. That was a wonderful talk. And it's amazing to see the leaps and bounds that you have achieved in your career so far, back from the postgraduate days when you were given, thesis topic of electrophysiology, and we were all flummoxed with what to do with this topic and how to go about it. So from there to now, in these 2.5 decades, it's just been amazing to see how much to see how high, what all you've achieved in this field. Very inspiring to the rest of us. And thank you so much for spending your time with us today. We'll move on to the
Thank you,
next.
Supriya. Thank you, everyone. Have a good evening.
Thank you so much. We'll move on to the next talk now. Manjula, can we have the introduction for Dr. Ashwin, please? Dr. Ashwin Malipatna.
It's late night for Ashwin.
It's as late as it is for Ajoy. It's actually early morning.
Okay.
It's early morning. Yes.
Okay.
Thank you, Ashwin, for joining us. Dr. Ashwin is a pediatric ophthalmologist and assistant professor and the current head of the retinoblastoma program at the Hospital for Sick Children in Toronto, where he's also received the Student Humanitarian Award in 2009. His research, particularly on periocular topotecan, has been recognized internationally. Dr. Malipatna currently investigates strategies for early detection of retinoblastoma. He's collaborated worldwide to improve retinoblastoma outcomes. He's facilitated the initiation of Iksha Foundation and an NGO in India that supports the care of children with retinoblastoma care, played a crucial role in developing the classification system, the staging system, and has influenced global treatment standards. And he continues his focus on innovative early detection and treatment strategies. So Dr. Ashwin is going to give us an update on the current management of retinoblastoma. Dr. Ashwin, so good to have you here.
Thank you very much. I'll start to share my screen if that's okay. But in the meanwhile, I'd really like to thank the organizers for having me, and it's really an honor to present in this forum. And to present with such eminent colleagues and people who we've studied with as well. So I think from St. John's to here, there's a huge journey, and I think my journey for retinoblastoma also started in St. John's, not as my thesis topic like Ajoy, but definitely as an inspiration, because we were the treating center in those days, and all the children who came in there were the reason why we all got into these fields that we did maybe. But my job today is to talk to everyone about what's next in the management of retinoblastoma. And I've been allotted 15 minutes for that. So I think it's going to be a bit tight in time. I want to just say that I unfortunately have no conflicts of interest to declare. But I do have some internal conflicts to declare, in that many of the children who I've treated have come from families with no financial support at all. And a lot of them still find it hard. And, the contents of this presentation is entirely owed to all of my patients, teachers, students, and colleagues. And there will be some discussion of what's latest and unpublished as well in this presentation. I do have a lot of slides to cover, but I'm only going to limit this to 15 minutes. So I think what I will do is I'll just stop at 15 minutes. So I think I'm keeping a tab of time, and please let me know if I run over time in any other way. But this is sort of the direction we'll go in, and I want to use this opportunity to present this like a case presentation, So we'd follow a case through and see how things have changed in each step of that presentation. So what we're going to truly start talking about next is diagnosis and how things are with that. I want to present the case of a child who's a 2-year-old. This child has had unilateral leukocoria for about 3 months and intermittent congestion for about 2 months. And they went to an optometrist who then discovered that there was a raised intraocular pressure, treated with eye drops and referred to an ophthalmologist, but unfortunately did not reach the ophthalmologist in any urgent way. Which is why, and of course, this child is a Canadian child, and we don't expect there to be this kind of a delay. While we do expect that there are social barriers in most places in the world, including when I was practicing in India, I think those kinds of barriers are surprising sometimes when we see them here. In this situation, if the referral is not made urgent enough, and if people are not aware that this is this requires such an urgent referral, things can be delayed as well. And that's what I wanted to start talking about. And to introduce that, I wanted to talk about this baby who I saw when I was practicing in India. This photograph was taken by a village photographer, and this village photographer took a photo of this child and during the child's namkarana, and at that point went over to the parents of the child and said, there's this white reflection coming out of the eye. This child might have cancer. Now, how did this village photographer, who's not even medically trained, know so much? It just so happened that this photographer's niece had passed away from retinoblastoma, and therefore he knew about the white reflex. So this photographer saved this little baby's life, but it took the death of one child to inform people about signs that could save another child. And that is entirely too expensive a lesson. We have to do better than that, and we owe our world a lot better than that. There we go. So with Iksha Foundation in India, of course, there's been a lot that's been happening. That they've been trying to put posters everywhere in India, and they dance in the street to make sure that the awareness of leukocoria is spread, and that carries a lot of weight. There was something else that we had investigated a long time ago in India, which was the use of digital cameras in producing these red reflexes and maybe screening children using these red reflexes. The compact digital cameras quickly got replaced by phones. Therefore, the phones didn't do as well as the compact digital cameras for various reasons. And that's the reason why a project like this was not sustainable. But what we did understand at that point is that there were abnormalities that were more obvious to the village health workers who were performing these photos and screening, and more subtle abnormalities were not so obvious to them. But it just so turned out that the subtle abnormalities were also not as urgent as these obvious abnormalities, such as a loss of a reflex or a white reflex. And it's quite clear to see over here in this photograph that this white reflex is from a coloboma, but requires a referral nonetheless. However, red reflex test training is something that's quite has room for improvement going forward. Training truly lacks fidelity, which means that we learn through diagrams or photographs as medical students, and instruction sessions really lack real disease, because all of these diseases that we're talking about are rare, and most experience is only with peer-to-peer practice. Learners are not exposed to physiological variations in fundus pigment as well, which there is a range in India as well, but the range that we see in multicultural societies like Toronto is quite vast. And quite often the pigmented races are the ones who are not benefited by the lack of training in this diverse pigment situation. And on the other side, of course, doctors are quite rightly held to quite a high standards. And if they have not properly performed the red reflex test, then they could even be sued, especially in this part of the world. So to try and meet that problem, we've actually devised these 3D printed eyeballs. And these 3D printed eyeballs are printed in full color. And they're printed to be optically accurate. So they optically mimic different fundus pigments, and they also mimic pathologies that we can 3D print into the eye, such as a retinoblastoma, as you can see in this image. You can even go to this website here and download the files for 3D printing and 3D print on your own. Of course, the printer that we use is a relatively high-end printer, and I know that there are a few of those available in India as well. But we think that something like this will improve the way people experience the white reflex, experience these pathologies, and can therefore be better at screening things, including retinoblastoma, early. As I said, we changed the fundus pigment by altering the amount of pigment in each of these types of eyes. And that results in different kinds of red reflexes as well, which accurately mimics the variations in our society and hopefully mimics the pigmented races much better and represents them much better in training programs going forward. We've now created 3D models for red reflex training, and we're implementing this in the, we're testing it out in the University of Toronto's medical school, where we have eyes with central retinoblastomas, peripheral retinoblastomas, myopic eyeballs, cataracts, and corneal opacities. And we train them with all of this in a way that they've at least faced these situations before and are not confounded by this when they actually face that situation with a baby. So this is how it looks. Then these are practical OSCE exams. So the exams have these baby models over there, and people are meant to come along and perform these red reflexes, and therefore can actually be judged for their red reflexes. And this can actually now become a pass or fail mark for a medical student exam. And that's something that we're trying to implement going forward, hopefully with a much better uptake of the red reflex test itself. So going back to our unfortunate patient who hadn't gone through those steps to be alerted to the problem soon enough, when we saw the patient, the intraocular pressure was about 48. The eye was congested. We had started this child on Diamox, dorzolamide, and timolol. What next in this situation? What we do next at this time is to try and stage the disease. So let's talk a little bit about staging. So an eye that looks like this, where we can't see anything in the vitreous, behind the lens, it's a very hazy vitreous, and you can't really see a discrete tumor. We relied on the B scan, of course, to even make our diagnosis. And once that was done, the exam under anesthesia would also show you that there's neovascularization, and that neovascularization would tell us that this is neovascular glaucoma. Therefore, an eye that is significantly hard to retain. Therefore, an enucleation was suggested. Parts of the world would perform neoadjuvant chemotherapy in this situation. And in our practice, we try not to do that because we would want to know the pathology a lot more. I know that there are many centers in India that would give neoadjuvant chemotherapy in this situation, and that has been discussed by France a long time ago, or by the French investigators who've described that neoadjuvant chemotherapy makes enucleation in these situations easier. There are situations that can happen in enucleations like this that actually worry us. And I'm actually going to describe a situation like that. But before that, I want to, start the discussion about what classification will you use to try and classify an eye like this. So an eye like this in some parts of the world, or in most parts of the world, by whichever system that you go by, will be a group EI. And a group EI would tell you that this is an intraocular tumor. And just to tell you a little bit about the ABCDE so far, for those who are uninitiated, small and peripheral tumors are A, larger posterior tumors are B, those with focal seeds are considered to be C, and those with diffuse seeds or large amount of retinal detachment is meant to be D, and EIs are those that were meant to be unsalvageable, destroyed, or dangerous was the description. However, we soon started, we were initially thought that all EIs should be nucleated, and our child with the glaucoma that we're presenting to you also has that kind of glaucoma. So in this situation, of course, when we see eyes like this, we wonder, is this group D or group E? And I ask that because there are two different versions of the ABCDE. And in one version, the size of the tumor is very important. And in another version, that is not even mentioned. So if you have this inconsistency in the way group D and group E is described, you're not even talking on the same page at that point. There are people who've gone around that and sort of made a hybrid definition of a group EI. And this hybrid definition has taken components of both systems and fused them into making their own system, which is actually not a bad thing. And it serves their purpose really well. But the confusion goes deeper than that. The confusion even goes into where the meta-analyses that have described the successes of treatment. Let's say in this case it's intraarterial chemo that's been described here. If you look at ABCDE and all these papers, if you actually read the papers in some depth, you'll understand that they've all used different systems of classification. And perhaps some, the part that really gets me is that some of them have not even specified which system of classification they've used. And we have to then go and infer what they mean by their results. So truly there's confusion in this field. And this confusion we tried to abate by going forward with the next edition of the AJCC, which described tumors in stages, which is an intraretinal tumor, becomes an intraocular tumor, becomes an advanced intraocular tumor, and then extraocular. And this hierarchy or this progression is quite nicely described in T1 to T4. And if you look at the details, it gets a little bit more confusing, and I can't do that in 15 minutes for sure. But if you truly look at what T3 tumors are, or the advanced intraocular tumors are, these are just tumors that have infiltration, invasion, ischemia, and inflammation. And if you have any evidence of this, then you should be calling them a T3I, or what used to be called an EI for some people. So I think this makes it a lot simpler. And this may be one of the changes that happen in the next version of the AJCC that is coming up. But what next? The next thing I'd like to talk about is imaging. I think I'll do this very quickly because I'm running out of time, but I'll reach the end of imaging and I'll stop right there. So these eyes truly can't be described as group D or group E. We already discussed why that's confusing and why we should go into the CT2B eyes. But truly, when you look at the MRI, we've started to recognize these MRIs that show high risks of signs in the choroid, such as this fusiform swelling that you see right here. And sure enough, soon after we nucleated that, we found that this the high risk feature that you could see in the MRI closely matches that in pathology as well. Therefore, and obviously you need better MRI protocols to do that. And so here's a link to all of our MRI protocols. If anybody wants to use those MRI protocols, they're free to do so and create their own high resolution MRIs for patients with retinoblastoma. But now we also discovered that if you can see invasion, then this is not a T2 eye, it's a T3 eye. Therefore, this is truly a proper EI and not a DI, and a more high-risk eye than we really thought. So, of course, there's another staging system that will say that this eye pre-enucleation is stage 0, but after enucleation is stage 2, and that confuses things for the oncologists as well. This is another similar case where you could detect the high-risk pathology in choroid before we actually enucleated the eye. Therefore, a CT2I again is converted to a CT3I, and that we've confirmed with pathology again in this situation. So that's becoming more frequent. But to go back to our patient had this sign in the MRI, which is the optic nerve being involved. So that straight away takes it to a CT4A. And this is not an intraocular tumor anymore. Therefore, you can't use the group ABCDE system for an extraocular tumor. Using the TNM system is therefore much more robust in that way. So truly, in the assessment of severity of tumors in 1960, we only had the ophthalmoscope. In 2005, we had a lot more than that. And in 2025, we certainly have the MRI. Therefore, the Rees-Ellsworth classification was being used at one time, the international classification at the next time. I truly think it's time to move on to the AJCC. We can use this as well, but I think we should truly move on going forward. So that's the advantage of the AJCC, and I want to quickly go into what's next, especially to talk about staging that informs treatment. I'm not going to talk about all forms of treatment. I'm only going to talk about enucleation and specialized today. I don't think I'll have time to talk about everything else. So in this case, if you look at all the possible options that we had, we chose enucleation. And the reason we chose enucleation was that we don't do systemic chemotherapy in a situation like this because we want that pathology information to tell us what we have to do next. And that pathology information gets hidden when you give systemic chemotherapy. So again, going through this child, we decided to enucleate, and enucleation, I don't have a photograph of enucleation, but this is what we did in this situation where we held on to the muscle stumps with sutures because we wanted to be careful about that. We also held on to the medial rectus with a forceps, and we enucleated with that. But during our enucleation, getting the eyeball out was not simple at all. And in this situation, two things happened. One is that the stump that we had tied for the medial rectus, the suture just gave completely, and the suture came off with a partial sclerectomy, which is known in these eyes with glaucoma. And what also happened because of that is that we had inadequate traction. Therefore, we had a laceration of the optic nerve and a complete transection of the optic nerve posteriorly there as well. So now that we know that the MRI had shown us optic nerve features, we were very worried about that cut. Possible explanations for the muscle avulsion that happened with the enucleations with glaucoma is that increased hydration will decrease the scleral stiffness, which is the converse of decreased hydration increasing the scleral stiffness. And glaucoma that shows changes in the ECM actually alters the biomechanical properties of the sclera, therefore making it easier for this avulsion to happen. Long story short, for the pathology, we found high-risk pathology, but none of that high-risk pathology had gone to the cut end. In other words, the avulsed medial rectus did not have any tumor, or the sclera didn't have any tumor in a significant way in that area. And thankfully, this child's management was a lot simpler. We only needed adjuvant chemotherapy, prosthesis fitting, and radiation. So to try and avoid that complication, we've done a few things. Of course, I think the three things that are normally done, which we did even in the last case, was a canthotomy cantholysis, a suture to the medial rectus, or suture to the recti stumps, and holding on to the suture. So holding on to the stump with a forceps to enucleate the eye. But what we went ahead and did for the next case that we got that was similar to the last case was using these sutures, which we are calling straddle sutures for the optic nerve. And this is a video that describes that. And I'll quickly run that video to show you that we use a silk suture with a gas hook. And the silk suture is passed around the optic nerve on one side. And similarly, we pass another silk suture on the opposite side. And the eyeball is then held up like a hammock. And holding the eyeball up like a hammock like that actually allows you to bring the eye quite far anterior, and deliver the eye much safer in these situations. And the reason why we think it's a bit safer is that delivery of the globe can happen in two ways: traction, which we apply from in front, or propulsion, which you can apply from in the back, which is what the suture is doing. And traction in the front is these sutures to the muscle stump or forceps to the muscle stump. Propulsion you can do with an enucleation spatula, but often there's no space in a ophthalmic eye in these infants. Therefore, the straddle suture technique is something that we would advise be done in these situations. So I'll stop there. So I'll go all the way to my last slide, which says, what's next? My time is up. And therefore, I won't discuss the rest of the presentation. And thank you very much. I'm happy to take questions if there are any at this point.
Thank you so much, Ashwin. That was a wonderful talk. I know 15 minutes is too less to try and sum up management of a life-altering disease like retinoblastoma. But yeah, what to do? That's the time we have. Yeah, that was a wonderful talk.
I'm happy to
So
give
I'm
my
going to
other
open
15
to the
minutes of the talk some other time if you want me to, but yes.
Sure. We'll do that. We'll hold you to it. I'd like to open it out to the panel. Dr. Gopal, Dr. George, any questions from the panelists?
There's just one question.
Yeah.
If you have a glaucoma,
Yes.
but with no evidence of extraocular extension on MRI,
Yeah.
but has the glaucoma is because of neovascularization of iris, but not tumor infiltration of the iris.
Yes.
I thought you are justified in trying to save the eye by using intraarterial chemo. In fact, I had one case which I managed in Singapore, and the patient ultimately did quite well and retained useful vision as well. And the glaucoma actually got reversed partly. The child does need some anti-glaucoma medication, but eye is preserved after just 3 cycles of intraarterial chemo. They became totally all right. So I think we need to differentiate what is causing glaucoma, and of course, the tumor itself per se, or to identify whether it's treatable or not. Like in the entire eyeball filled with tumor, like what you showed with the optic nerve invasion, I would definitely think that you have to nuclear. I understand that. But this is one question. The second point I was trying to think is about the enucleation technique.
Yes.
I was using some time in the past where you cannot put a spatula on the enucleation spoon as we used to.
That's true. We don't use an enucleation spatula as well. We only use traction from up front, but traction from up front in these globes with glaucoma is obviously much more tricky. Therefore, I think this suture technique was devised as a method to overcome that conundrum. But I want to go back to the mention of glaucoma and whether we perform chemotherapy for globe salvage in those situations. And I understand that that is a practice in some parts of the world. I think that our thought process is the pathological information that we lose. There are situations where systemic chemotherapy has been given to salvage an eye without recognizing those microscopic signs that you can sometimes not even detect on MRI. We don't truly know the false positivity and false negativity of these signs that we're discussing, which will be something that we would know more in the future when maybe MRI resolution improves. But if we lose that pathology information, then we're not entirely certain whether we've treated all the disease. And if there is any residual disease in the orbit, especially, I think that kind of disease tends to come back. I understand that some of that can be covered with chemotherapy, but truly, I think radiation is needed for some of that spilt disease into the orbit. You may not miss so many of that if you if you go ahead and treat with chemo, and chemo was adequate for that situation. There are the other situations that have been described in South America by Guillermo Chantada and other places where chemotherapy itself is the reason for a child's death because of the toxic complications that happen after chemotherapy. And we do know that 4% of those with who have any form of etoposide can get hearing loss as well. So yes, we're salvaging the eye, but we always give the choice to a parent in situations where there is a choice. And I understand that there's a hesitation to enucleation, and we certainly see that hesitation to enucleation even in Toronto. So it's not unique to only my practice in India when I was practicing there. But we certainly see that here as well. However, I think there's a more balanced approach, and if we truly involve the parents in this decision, they can make the decision on whether they want to save the eye or not. And if they want to save the eye and we see no risk for that, then we obviously encourage them to want to save the eye, even if there is, even if we don't expect eyesight in that eye. Yes.
Thank you, Ashwin.
Can I make a statement, Supriya?
Yes, please. Yes.
I think my internet connection has been going on and off, so I was not able to listen to everything specifically. I just wanted to say that one technique of enucleation I was doing, at least when I was doing in the past, was to prolapse the globe in front of the eyelids. That is, if you push the eyelids gently back, the entire eyeball comes in front of the palpebral fissure. Then you get more space to introduce instruments around the eyelid, even in a ophthalmic eye. And also, the eyelids themselves try to push the eyeball forwards. So I usually get very good length of optic nerve using this technique.
Okay. That's a good point, sir. I hadn't thought of that.
Good to see you, Ashwin, after a long time. And
good to see you, George.
And though this is not my specialty here, Parag takes care of the retinal hospital in Arvind. So I know, good to see your interest in early detection. So and treatment. I just want to know with treatment, do you use a selective intraarterial chemo, and then how often you do, and how is your experience with that? And now good to
I think we've published our experience recently, which was single versus triple drug chemo for intraarterial, and we have quite a regular we quite regularly use intraarterial chemo for a lot of our patients, especially unilateral and recurrences. We think that intraarterial has the benefit of having a harder hit and fewer cycles required, therefore, and a lot less systemic complications. So no risk of hearing loss, no risk of neutropenia. It's a much better and more effective way of delivering chemotherapy where it's possible. So I certainly think that systemic chemotherapy and intraarterial chemotherapy both have a role, but we find ourselves using intraarterial a lot more for the unilaterals nowadays, of course. The situations where we cannot use it is when the child is extremely young, or in some bilateral situations where we feel that favoring an eye is not the optimum thing to do, and very, very rare situations where we fail to cannulate with intraarterial chemo. So for intraarterial chemo, at that point, then we've fallen back on systemic chemo as well. But we're quite comfortable with intraarterial chemo, and we're quite happy. We've noted a lot less recurrences after intraarterial chemo and more recurrences after systemic chemo. So I think the total dose going to the eye is a lot higher.
And with the selective intravitreal and intraarterial, I think you have a lot of less complication, more salvaging smaller lesions, I think, isn't it?
That's exactly right. Yeah, with that, with intravitreals now using topotecan of much higher doses, I think we've gotten a lot better at eye salvage than we ever were before. I think vitreous seeds was one of those pain points, at least when I was a fellow 18 years ago. Now it's not a pain point as much as it used to be. It's still a problem, but it's a surmountable problem mostly. Yes. And melphalan, of course, had the disadvantage of causing a retinopathy, but topotecan's a lot safer for intravitreal injections. We are hearing of rare instances from different countries where the injection site has been infiltrated with tumor. I think that is poor technique. If you follow the rules, the safety enhanced techniques for intravitreal injections, then you shouldn't be getting any of that. And obviously, you can't use intravitreal as a primary treatment. It's obviously an adjuvant treatment. So, intraarterial and systemic chemo go first.
Thank you. So all the best to you. Yeah.
Thank you.
Thank you so much, Dr. Ashwin, for the wonderful talk, and look forward to hearing the rest of your talk at another day. I'd like to move on to our next speaker. Manjula, can we have the slide for introduction, please, for Dr. Nicholas? This is the last talk for the day. Next slide, please. Welcome, Dr. Nicholas Lapuri. He's the director at Da Vinci Eye Clinic at Georgia and the visiting vitreoretinal surgeon at Baku, Azerbaijan. Not only is he an accomplished retina surgeon, but he's also done multiple cornea fellowships, and he was the founder of the Georgia Society of Retina Specialists. He is published in numerous international journals, is on the editorial board of the International Journal of Retina. He's an inventor of numerous surgical techniques, and in both retina as well as cataract surgery, and that's what he's going to talk to us about, his watch technique for macular buckles in myopic maculopathy. Dr. Laburi, on to you.
Hello, good evening, good morning. Am I audible? I'm not sure.
Yes, Nicholas, you're audible.
It's a big honor. It's a big honor to me to be invited at this webinar. I'm so glad to see my mentors and my colleagues from around the world. So today I will share the presentation. Yeah, now it's on the screen, I guess. Okay. So today I'm going to speak about the new technique and new device for the myopic traction maculopathy in high myopia cases when we have a big spectrum of the disease, and we know that MTM, it comprises a lot of clinical manifestations that can be seen separately or in combination, like a myopic vitreoschisis or retinoschisis, the lamellar hole, full thickness hole, or the posterior detachment. So it's quite an old scans taken just to show the clinical examples here. We see there is a posterior staphyloma, central staphyloma with the vitreoschisis here. The next slide shows the retinoschisis only. Here it is a retinoschisis with a retinal detachment, but not the full thickness hole is not yet developed here. And this is a case when we have the retinal detachment with a full thickness hole. Actually, here is a silicone hole inside the eye. So it is taken after the unsuccessful surgery. So we know that most of these cases, when we are dealing with MTM, they are treated with standalone vitrectomy with or without island peeling in most of the cases, but still we have some clinical scenarios when we see the OCTs and we have a feeling that there is not enough tissue of the retina, even if we do the ILM peeling and make it mobile to cover all the wall of the RPE and close the macular hole. So that is why the macular buckle was invented. So this history goes back to 1950, when the first scalpels used some implants to suture onto the posterior pole of the eyeball. And of course, it has the numerous advantages because it shortens the axial end. And of course, it has increased rate of macular hole closure and the retinal reattachment in cases of myopic retinal posterior retinal detachments. So as we know, there are 13 different kinds of staphylomas, but mostly we have to pay attention into the central narrow or wide posterior staphylomas when those are the best candidates for the macular buckling. And in case what you see on your left, in case if you have the barrel shape globe, in most of the cases, the primary vitrectomies are most successful. On your right, you see the posterior staphloma, which is shifted onto the nasal side and involves the optic nerve or the nasal part from the optic nerve. So here is the classification of the MTM, and accordingly when we have to intervene and what kind of surgery we have to do. It is suggested by Dr. Parolini. It's quite useful guide, the clinical guide when we treat our patients. For example, me personally, I consider almost all of them, but some of them I'm doing differently, but mostly it's quite good work and good classification, which is very useful nowadays. So you see here different kind of implants suggested by different authors in different times, and mostly me personally, I have the experience with the endoplomb, which is not anymore available in the market, and now we have the AGL plombs, MBP plombs, which has two different designs. The previous design, it was just the indenting head, and it's a PMMA implant, and now it was a little bit changed, but more or less the indenting part is the same, which includes a more dome-shaped surface, and when you implant this device, so you have dome-shaped indentation. So this is what we do now the last 1.5 years. This is the regular implant actually is assembled by the buckling elements, which we use every day in our practice. So here you see the 240 band and the round indenting part, which is harvested from the solid silicon rubber, solid silicon tire, and this band actually passes through the scleral tunnel and it's fixated onto the supranasal and infranasal part. So when it's tightened, then it indents the indenting part and treats the outpoaching of the posterior sclera. So I will show in some clinical cases here. So far we have done 9 cases. Because in our country it's not very frequently seen disease. That's why it takes a lot of time to gather some amount of patients to do the publication. But here we see the posterior retinal detachment, the limited retinal detachment, and the OCT shows there is a VMT, there is some epiretinal membrane, some schisis on the neurosensory retina, and the retinal detachment, but still the macular hole is not developed here. So in those cases, we have to be very careful to do only vitrectomy, even with the fovea sphering island peeling, in cases when it becomes more mobile and reattaches onto the RP. So we may create the iatrogenic macular hole, and it's quite frequent complication. So here is the technique which shows the preparation of the implant, which we do. Here is a B-scan of the same patient, and this patient is phakic patient. We are not going to touch the lens here because once we shorten the eye globe, of course, then we are accompanying this with a gas or air, and we are expecting the cataract, and we need more precise calculations when we do the cataract surgery. And here here you see I'm using the corneal trifine to harvest the round shape silicone rubber, and I'm doing the scleral tunnels inside to pass the 240 band, and it's resembling the wristwatch. That's why I call this wristwatch buckle. So I just I'm showing here to tag how I tag the muscles, and it's very important to isolate inferior oblique muscle and pass this band under the inferior oblique. Otherwise, if we don't go under the inferior oblique muscle, we will not be able to place the indenting part of this buckle under the fovea, which is very important. So I'm combining this case with a vitrectomy. However, this case could have been done just with a buckle first and the vitrectomy as a second part, since we didn't have the full thickness macular hole yet. It's very important to use the high magnification lenses, which gives you the high stereopsis. Here you see I'm using the AVI macular window. It's very important because you need to see what you are pinching, because with a pinch you may create some holes later on. You see the indentation now when I do the fluid air exchange. This indentation, I'm just for demonstration here, but it's not necessary to indent too much because it is related to the metamorphosis, and you see on the B scan before and after, the OCT before and after, there is still some residual fluid, will take some time to reabsorb, and MRI, which shows the very central placement of the indenting part, which indents the posterior sclera. So this is the same patient on the white field, and you usually use and follow up these patients with autofluorescence because we are very much concerned about the RP changes after the buckling element. Since I'm doing this macular bucklings since 13 years now, I have seen a couple of cases where the RPE is gradually deteriorating, and there are two different hypotheses. One hypothesis says that it's a natural course. However, a few people think that, few authors, they think that it's because of the indentation. So this is another case just before and after. On the left, you see the posterior limited myopic detachment, and on the right there is the postoperative photo which shows attached retina. Here is how it looks after the indentation. When you and it was done the vitrectomy as well. And when you do the surgery, sometimes you have some residual fluid, and it takes quite a long time to reabsorb, maybe 6 months to 1 year. And gradually, patient feels the improvement in vision. And also, please pay attention onto the shape of the indentation, which is flat instead of being dome shape. And this autofluorescence of same patient before and after. And the B scan before and after, just adjacent to the optic nerve, you see the implant itself. This is third case, on the left detached retina, and the right 2 months after the macular buckle. So this is a case with a full thickness macular hole in the posterior staphyloma. There is some epiretinal membrane in the foveus chysis as well. And we have done, you can see the indentation of the buckle, and we have done the inverted flap technique. However, it's not necessary. You can do just a regular peeling, and in most of the cases it works very well. And then the closed macular hole and autofluorescence of before and after the same patient. This is a B scan, just the optic nerve just below, and it's a radial B scan, the vertical, and the indenting head just next to it. So there are numerous advantages of this technique. The first and foremost, when we are talking about the macular buckling, this technique is more than now 70 years around, but it has never became so popular, and it has its reasons. One of the reasons is a learning curve, of course, and another thing is the skepticism which is related to the progressive RPE atrophy because of the indentation. and of course the metamorphopsia. So all the buckling elements suggested before, the most of them they have the round indenting surface, which gives you the dome shape indentation, and of course it is related and it causes very significant metamorphopsia, which causes a distortion of the vision. I have a few patients with AGL plombs where patients are achieving 0.6, 0.7 vision in decimals. However, patients are not happy because of the metamorphopsia, and we cannot do anything with that. In this case, when we are using the tire, it has the concave surface, the indenting surface, instead of convex. That's why more or less when we do the indentation, the surface of our indentation is not that much round. So that's why it's related with less metamorphopsia. However, metamorphopsia is still there. Another thing is that you don't need to order this implant, and we know that the AGL implants now, they are custom made. You need to send to the companies the actual length measurements. You need to wait for at least 2 to 4 weeks until this implant arrives in your operating theater. And I have seen the cases where we have the limited detachment with a macular hole, and until the implant comes to the operator to the clinic, the detachment progresses completely and involves entire retina and becomes more challenging to operate. And also there is the less extrusion risk, because when we use just one arm implants, you know that you have to suture it onto the sclera, and sometimes you see when you look at the slit lamp, you see that you have some bulging under the anterior subtenon space, and sometimes you have some extrusions. You need to remove the buckles, but in this case, if you examine the patient with a slit lamp, just a sclera, you will even it will be very hard to notice where it is placed, since there is only a small fixation points on, say, supranasal and infranasal quadrants. However, this the technique, yes, this video just I want to show you after AGL plomb with a dome shape indentation. This patient I did, I think, in 2013 or 14, has quite a good visual acuity. However, it's not an only eye. That's why she's not happy with the metamorphopsia. And you see how the dome shape indentation looks, and it has a 5 millimeters indenting part to compare to this new buckling, which is a 7 millimeters, so it's much easier to capture all the posterior, the most of the part of the posterior pole and evolves and foveal region. And with dome shape implants, the problem is that it's very hard to hit exactly the center of the fovea, and sometimes the fovea is attaching onto the slope of the indentation. This is another reason of the significant metamorphopsia after the surgery. So the dark sides, of course, this technique, it has the dark sides, because the first is that we need to open the conjunctiva 360, and we need to tug all the muscles, including the inferior oblique, which is not that easy sometimes to tug it. And if someone is not so well familiar with the buckling techniques, which is, as we know, the last 1 decade or 2 decades, the people who are trained in the vitreoretinal surgical fellowships, they are not taught how to do the bucklings, and it will be very difficult for them. And also it has a learning curve. Of course, it's very steep, and also the problem is that we don't know still whether it causes the progressive RPE atrophy because of the indentation or not. And another thing is that it's quite complicated anatomical area in that place because we know that, however, when the eyeball is elongated, the anatomy is changed completely. But we know that in this region we have the posterior short ciliary arteries, posterior long ciliary artery with a nerve, and it's quite a complicated area. However, we don't have the systems, the devices to visualize what do we alter with our surgery, which of these elements. So we need more material, and however, I have few cases with very long follow-ups, 10 years and so, but with this particular implant, we need, of course, a longer follow-up to just make any solid statements. So we did the primary publication in the Retina today, and Dr. Supriya's contribution is huge in here, but still we are trying to collect more cases with a longer follow-up and publish it in peer-reviewed journal. Thank you so much for your time, and again, thanks for the invitation. It's a big honor to me, and very happy to see you.
Thank you so much, Dr. Nicholas. That was a wonderful presentation, and the video was excellent in your demonstration. As usual, you're always trying to do things in a different way and try and bring out the best surgical results. Thank you so much. I'm going to open it out to the panelists. To Dr. Natarajan, you've always wanted to do scleral buckle in different ways. And you started the trend of sutureless scleral buckling almost 20 years ago. So what is your take on this technique by Nicholas?
I think I'm always, he's a great inspiration, a great surgeon. Even similar surgery he did for the inferior retinal detachment. I think after that, Nicholas didn't follow it up, but I think that was a new thing which he was doing when he was with us in Aditya Jyoth, maybe in 2009, I think. But I mean, it's a great procedure, and I keep following with Barbara. Barbara is a good friend. She has come to Mumbai too. But I think Nicholas is a out of the box thinking person, and I'm glad. I'm very happy that this should work. And is this buckle available now for commercial use?
Yes, regarding this buckle, so no, it's not commercially available. However, everybody of us, we have the 240 band and 278 tire, and the 7 millimeters of the corneal refined just to prepare it before the implantation. It takes about 10 years. 10 minutes, I'm sorry. And I always assemble this implant just before the surgery, before I open the conjunctiva. So that's why, so it's not yet, but we are, once I make sure clinically that it's really valuable and it's not related with the major complications, then I will speak with some companies. It's very, very easy to manufacture, actually. It's just a silicone rubber, and it doesn't need any special sizes. So it's you have the band, and you can adjust this size during your surgery according to the actual length or the eye size. And thank you so much, because the tunnels are very important, and the buckling, of course, as I learned it from you, this sutureless bucklings and the same technique I use here just to pass this band and fixate into the eye globe. So that's why it makes the sutureless all this procedure, which is very important as well. So thank you so much.
Happy doing
Thank you so much.
than me now and demonstrating to Europe. Very good. We are proud of you, Nick.
Thanks a lot. Thanks a lot.
Dr. Dhanashree, I know that you all also do a lot of macular buckles. How different is your method compared to what Dr. Nicholas has just shown us, demonstrated?
Yeah, first of all, a very nice talk, Dr. Nicholas, and very nice to see your videos. So I personally don't prefer to do myopic buckle for myopic maculopathy or even myopic macular hole. So that is Pradeep and Dr. PB, and I think LT sir also do that. So my go-to technique is actually eye vitrectomy and ILM peeling. But I think more or less similar technique is done by in our institution also. But my, my concern always was, like Dr. Nicholas mentioned, whether the RP atrophy and the choroidal atrophy gets aggravated by all these measures. Because even after, say, if you have done ILM peeling also, so I have noted that after ILM peeling, even when the retina gets attached, but you will see that the retina gets thinned out. So many of these patients, they may have a loss of vision following the ILM peeling. And similarly for myopic, but for the buccal also, the macular buccal also, many of the patients may have a progression of the atrophy of the RP and the choroid there. So those, I think we also have to take into account that progression. Despite the retina being attached, the maculopathy progresses. So that is something we need to look into. But lovely technique, yeah.
Yes, I absolutely agree with you. With regard of the indentation and the progression of CRP damage, it's very difficult now to prove whether it's a natural. However, there are several publications which proves that it's a natural course and not because of the indentation itself. However, we don't have the material where the both sides are taken and for a long time, so we need to observe one eye, which is a 3D eye, and another eye also. And however, this the progression of CRP atrophy as a natural course doesn't happen simultaneously in both sides, so it's very difficult to catch this moment. However, I have one patient where the visual acuity was very good after the vitrectomy and the buccal. It was 0.7, and the patient after 7 years came to me with a sudden loss of vision. She noted that it was from 0.7, it's reduced to 0.07 or something like that. And it happened within 4 days. And then I have taken, and I already had the autofluorescence taken before. I was taking it every year. And when I compared the last autofluorescence to the previous one, it was the remarkable RP atrophy exactly as at the center, exactly at the indenting zone. However, on the other hand, the major advantage of the macular buccal is that in many cases we can use the macular buccal without the vitrectomy, and the vitrectomy is always the ILM peel is always and as well very traumatic procedure. We know that even in cases when we don't have high myopia and we peel the ILM, we see the neurosensory retina, it gets thinned out, not because of the ILM is removed, because of its atrophic and it's a major trauma to the neurosensory retina. And the buccal, in cases when we don't have the macular hole, just a detachment with a schisis, you do standalone macular buccal. Usually you achieve very good visual acuities, and then the retina is attached, and the vitreous is inside. You spare the lens. You don't do the vitrectomy. It's a still fake patient. So it still has advantages. I'm still trying to find out whether it's worthwhile to do or not. However, there are many controversies, and I think it will be after 100 years as well. So
I think we should do a head-to-head comparison between myopic buccal and ILM peeling. That would
yes,
give us the
it would
answers.
be amazing since those patients are not too many, because we hardly in our country we are 3.5 million populations. That's why even from neighbor countries they are referring to me. We are getting about 5 to less than 10 cases every year. So there are very few now to. That's why unless we have the big material, we can't do any conclusions.
Just one question to Dr. Nicholas. Since you do both vitrectomy and ILM peeling, which we do, multiple layers of vitreous removed and a wide ILM peeling is what we all do because macular buccal is not available. So since you have both the options, is there any particular case which you would not do vitrectomy and use only macular buccal?
Yes, of course. Actually, because of this is a new technique and we are trying to do the best, that's why we are approaching too aggressively, to be very honest. However, in cases when we don't have the full thickness macular hole and we have the posterior detachment with or without the retinal schisis, even if we have the retinal proliferation and we have the retinal membrane, and there is no macular hole, because just standalone buckle is not going to close a hole. If there's a hole, you need to do the island peel. In those cases, I do the standalone buckle. And in most of the cases, it does very well. So those patients are doing very well because you are doing the contraction, the retinal membrane, the traction from the retinal membrane is not all completely, but partially released, and the retina gets reattached as well. It takes more time the fluid to reabsorb, so you don't see the next day. Next day you see that the fovea is indented, but next to the fovea there is still some. I should have placed these cases as well in this presentation. So there is some fluid which takes about 1.5 years, sometimes very long time to reabsorb, and these patients are doing very well as a standalone. In case, for example, the first case I have shown here, I could have done just a buckle first not to be very traumatic for the eye. The buckle first and then observe if it's necessary, then I could have gone inside and done the vitrectomy 1 month, 2 months, 3 months later, and it's possible as well, unless there is a full thickness macular hole. If there is a full thickness macular hole, then we have to decide either do standalone vitrectomy or with the eyelid peel or in combination with the buckle.
Thank you. Makes sense what you said. Thank you.
You're welcome.
Thank you so much, Nicholas.
Thank you.
If we have no more questions, then yeah, thank you so much for your talk. It was wonderful, as always.
Thank you. Thank you so much.
Yeah. It is my great, thank you. It's my great privilege now to deliver the vote of thanks on behalf of Dr. Sujata Mohan, our president of Tamil Nadu Ophthalmic Association, and the entire organizing team of our scientific of Tamil Nadu Ophthalmic Association, Retina, to share their knowledge and clinical pearls. Your expertise truly elevated today's program. We're extremely grateful to our panelists for guiding the session so effectively. Thank you for your presence, your questions, and your involvement, which kept the spirit of learning alive. We are very grateful to our delegates because it is your engagement that makes programs like this extremely meaningful. So thank you so much. And I'm just going to pass it on to Dr. Sujata Mohan to conclude the CME today.
And before that, I just want to thank Sujata and Supriya for having a wonderful day, World Diabetes Day. Thank you.
Thank you, Nati, and thank you all the panelists and the speakers. I was just dumbfounded at the amount of advancement that has been taking place in the retinal field. I'm absolutely have no idea at all, and really very impressed. And it was a lot of learning experience for me as well. And on behalf of Tamil Nadu Ophthalmic Association, once again, thank you for joining us. And maybe we should do a single lecture. I think Supriya should look into it. One person, they have so much to say and then so much of knowledge to share. We should do something like that with a group of panelists. So with those final words, I'd like to thank all of you and have a good night. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you all.
Thank you, and thank you all. Good night.
Finally, we saw you.
Good night, everyone. Thank you.
Thank you, George. Right. Thank you, Supriya. Wonderful.